Welcome to the Hospital Medicine Unplugged podcast. For every hospitalist managing acute illness, there is a silent, often unrecognized killer that undermines all our best efforts. Hospital malnutrition.
That's absolutely right. The burden of malnutrition on our floors is it's massive, driving up complication rates, prolonging length of stay, and definitely increasing mortality.
Yeah, it really is.
So today we are executing a deep dive into the latest consensus and practical guidelines. We're synthesizing, the foundational ASPEN and ESPEN recommendations alongside some key invited reviews, particularly from the NEJM.
And our mission today isn't just to define these terms. We want to give you, our colleagues, a really practical, protocolized, evidence-based approach. We need to tackle this dual threat, the pervasive nature of malnutrition itself, and then that acute, sometimes catastrophic complication, refeeding syndrome, or RFS.
Exactly. Why this matters now is really about closing that implementation gap, isn't it?
I think so.
Yeah.
We all know we need to feed our patients, right? But that transition, the safe transition from starvation or near starvation back to adequate nutrition, it's incredibly complex.
It really is. Get the initiation wrong, start too fast without the right prep, and you trigger the metabolic chaos of RFS. You basically transform what might have been a chronic manageable problem into a life-threatening acute medical emergency.
Precisely. So we absolutely need to standardize how we identify the vulnerable patient and, just as importantly, how we feed them safely.
Okay, so let's start by grounding ourselves in the definitions. It's important to distinguish between these two aspects of the problem.
Good idea. When we talk about hospital malnutrition, I think we first have to move past the old idea that it's purely about, not getting enough food, simple nutrient deprivation. It's much more complex, especially in our acutely ill inpatient population.
Indeed. Malnutrition really has a dual etiology. First, yes, you have the classic picture, inadequate nutritional intake, what we might call primary deprivation. But second, and this is often more insidious in acute illness, is the inflammation-driven model. This is where the inflammation that comes with the underlying disease, think septic shock, malignancy, severe trauma, it actually induces anorexia and drives massive tissue catabolism.
And that inflammation piece is so key because it completely changes the metabolic landscape. You get these inflammatory cytokines, things like TNF-alpha, IL-6, and they actively accelerate muscle breakdown. They promote sarcopenia, that generalized cachexia. So even if we technically pump in enough calories, the body is stuck in this highly catabolic state. It's driven by stress hormones, by inflammation. Those calories just aren't efficiently used for anabolism, for building tissue back up, until the underlying disease process starts to cool down.
That recognition, that dual etiology, is exactly why the diagnostic standards have evolved. The consensus now, and this is highly emphasized in that NEJM review, points towards a systematic two-step process. First, initial screening for everyone. Then, if needed, diagnosis confirmation using the GLM approach, the Global Leadership Initiative on Malnutrition.
All right, GLM. Those criteria have become the gold standard, haven't they? Because they force us to look at both things. The physical manifestation and the underlying mechanism or cause. You need at least one phenotypic criterion and one etiologic criterion.
Let's unpack those phenotypic criteria a bit, because this is where the practical application gets, a bit nuanced for us as hospitalists on the floor. We're looking for objective measurements, things like weight loss, low BMI, or low muscle mass.
Okay.
For weight loss, it needs to be significant. Typically, we're talking more than 5% loss over the last 6 months, or maybe 10% loss overall, looking further back.
And the low BMI threshold, that needs specificity too, right?
Yeah.
A BMI less than 18.5 kilograms per square meter is a clear indicator, but we have to adjust that based on age, maybe even ethnicity.
Exactly. For older adults, say over 70, the BMI threshold is often higher. We might use less than 20 or even less than 22 because we recognize that body composition shifts with age, and older adults are just more vulnerable at slightly higher BMIs.
Makes sense.
And crucially, that third phenotypic criterion, reduced muscle mass, ideally requires objective assessment. This can be a point of, let's say, institutional friction.
Yeah, getting DXA scans or bioimpedance isn't always easy bedside.
Right. Those techniques give precise data, but they aren't standard bedside tools everywhere. So for us, low muscle mass often relies on validated surrogate measures. We might look for reduced calf circumference. That's actually a pretty strong predictor of sarcopenia, or maybe testing hand grip strength using a dynamometer. that correlates pretty well with generalized weakness and functional decline.
Okay, so we confirm the physical loss, the weight loss, low BMI, or reduced muscle. Then the other half is the etiologic criterion. That's either reduced food intake or problems with assimilation, like severe malabsorption or GI obstruction, something like that.
Correct. Or it's the presence of that disease burden or inflammation we were just discussing. So a diagnosis like severe sepsis or having undergone major abdominal surgery automatically puts a patient into that inflammatory category. You really need both pillars, the physical finding and the underlying cause, to solidify that GLM diagnosis.
And if we neglect this, the consequences go way beyond just how the patient looks. Malnourished patients face generalized weakness, definitely delayed recovery, and critically impaired immune function.
That increased susceptibility to infection, hospital-acquired pneumonia, surgical site infections. It just fuels the cycle of inflammation and catabolism. It creates this downward spiral that independently links malnutrition to longer hospital stays and, unfortunately, a significantly increased mortality.
Okay, that really sets the stage for the acute danger. Let's pivot now to refeeding syndrome. We really cannot overstate the risk here. It's a potentially life-threatening metabolic disturbance, and it happens specifically when we start nutritional therapy in severely malnourished patients.
Understanding the pathophysiology is absolutely the key to preventing it. During starvation, the body's metabolic engine shifts dramatically, right? Insulin secretion plummets, glucagon levels rise, and the body tries to conserve glucose for the brain, relying heavily on breaking down fat and protein for energy.
And during that time, key cellular minerals, think phosphate, potassium, magnesium, they shift out of the cell and into the serum, or they're simply depleted from total body stores over time.
Then we step in. We initiate feeding, especially introducing carbohydrates, and the whole system flips rapidly. This triggers a massive, sudden surge in insulin secretion.
The insulin surge.
That insulin surge acts as a powerful anabolic signal. It drives glucose rapidly back into the cells, and water follows along with it. But critically, it also forces those key electrolytes, phosphate, potassium, and magnesium, back into the intracellular space. Why? To support the massive activation of metabolic pathways, making glycogen, making fat, making new protein.
And it's this rapid shift, this intracellular rush, that causes the hallmark biochemical derangements we obsessively monitor for. Profound hypophosphatemia, hypochremia, that's low potassium, and hypomagnesemia. The total body deficit might not have changed much in that instant, but the intracellular shift leaves the plasma severely depleted. Levels can plummet to critical values within just 12 to 24 hours.
Let's maybe talk about the specific clinical dangers tied to each electrolyte, because for us physicians, knowing the why really informs the urgency.
Hypophosphatemia is maybe the most dangerous marker of RFS. Phosphate is absolutely essential for making ATP, our energy currency, and also for 2-cal-3-diphosphoglycerate, 2-hebl-3-DPG in red blood cells.
Right, and if 2-cal-3-DPG levels drop because there isn't enough phosphate, the oxygen-hemoglobin dissociation curve shifts hard to the left. That means hemoglobin holds onto oxygen much more tightly.
So the tissues become hypoxic, even if the O2 sats look okay.
Precisely. And furthermore, since ATP powers muscle contraction, severe hypophosphatemia can cause profound muscle weakness. This includes diaphragmatic dysfunction, which can lead directly to acute respiratory failure, potentially needing mechanical ventilation.
Wow. Okay, then you have the cardiovascular risks. That's driven by the hypokalemia and hypomagnesemia, which often go hand in hand in RFS.
They are frequent companions, yes. Hypokalemia, low serum potassium, disrupts the resting membrane potential of cardiac myocytes. This increases the risk of potentially fatal cardiac arrhythmias, including things like VFib, and you might see those characteristic U waves on the EKG.
And hypomagnesemia, low magnesium, it makes the hypokalemia worse, right? It makes it difficult or even impossible to correct the potassium deficit if the magnesium isn't also addressed.
Absolutely. Magnesium is also a crucial cofactor in so many enzymatic reactions, and its depletion lowers the threshold for ventricular ectopi. Specifically, it predisposes the patient to polymorphic ventricular tachycardia, or torsades de pointe. That's why we have to treat these deficits aggressively and usually concurrently.
Okay. Electrolytes covered. What about the neurological risk? Thiamine.
Yes, we absolutely must emphasize the critical neurological risk tied to thiamine, vitamin B1. Thiamine is an essential cofactor for carbohydrate metabolism, specifically for the pyruvate dehydrogenase complex.
Right.
So when we start refeeding carbohydrates, the metabolic demand for thiamine just skyrockets. If the patient is already thiamine deficient, which is incredibly common in chronic alcoholism, but also in other chronic diseases, prolonged vomiting, or just poor intake, we risk precipitating Wernicke's encephalopathy.
Wernicke's, that's a true medical emergency. Presents classically as that triad: confusion or delirium, ataxia, trouble walking, and ophthalmoplegia, eye movement problem.
It's entirely preventable with routine supplementation, which is why, again, thiamine isn't just a suggestion, it's a non-negotiable component of the refeeding protocol for all patients considered at risk for RFS.
Okay, so we've clearly defined the potential catastrophe. The next logical step, then, is identifying the patients who are walking on this metabolic knife's edge. This brings us to our second major focus: risk stratification.
This is absolutely a core hospitalist responsibility. Regulatory bodies like the Joint Commission have made systematic screening mandatory. They require that every admitted adult gets assessed for malnutrition risk within the first 24 to 48 hours. If we miss identifying the risk up front, we miss the chance to intervene safely from the start.
The key thing to remember, though, is that these are screening tools. If a patient screens positive, meaning risk is identified, that's what triggers the need for the comprehensive nutritional assessment using those GLM criteria we discussed earlier. That confirms the diagnosis and helps classify the severity.
Right. However, it's important to note, a patient can be malnourished without necessarily being at high risk for RFS, and potentially vice versa, though less common.
So once malnutrition is diagnosed, we conduct a distinct risk assessment specifically for RFS. This is typically stratified by how severe the pre-existing nutrient depletion appears to be.
So who is truly vulnerable? Who are we most worried about for RFS? The highest risk group includes those with really severe malnutrition, maybe defined by a BMI less than 16, or unintentional weight loss greater than 15% over the last 3 to 6 months. Definitely those patients. We also look very closely at patients who have had minimal or essentially zero nutritional intake, think prolonged fasting for more than 10 consecutive days. You know, the postoperative patient with a persistent ileus, or the patient with a high-grade bowel obstruction who hasn't eaten properly for a week and a half.
Those are clear setups. We also have to factor in pre-existing conditions and lifestyle factors that are known to deplete micronutrient stores, right?
Absolutely. Chronic alcohol abuse is probably the #1 culprit there. It drives chronic thiamine and magnesium deficiency, among other things. Other major predictors include uncontrolled diabetes, mellitus, chronic malignancy, severe inflammatory bowel disease, or just high disease severity scores on admission, like we see in severe sepsis or septic shock.
And we could pay really close attention to those contextual predictors that are easily accessible right from the admission labs. These are the immediate red flags: low baseline serum phosphate, potassium, or magnesium levels, even if they're just slightly below the lower limit of normal. Those are screaming warnings that the total body stores are already depleted.
Exactly. When you initiate feeding in that patient, those intracellular shifts are going to be rapid and potentially catastrophic.
What else? High baseline creatinine may be suggesting some renal compromise. History of chronic diuretic use.
Yes, those are predictors too. Diuretics can further deplete potassium and magnesium, kind of setting the patient up for a vicious cycle of RFS fluid shifts and potentially worsening renal function. So meticulous risk stratification here directly dictates how intensely we need to apply our preventative care strategies.
Okay, this brings us right to the operational reality, section 3, evidence-based management. We need practical protocols for preventing RFS while still actually treating the underlying malnutrition.
Right. For malnutrition itself, the goals are, on paper, straightforward, but often really difficult to meet in the acute care setting. Daily energy requirements generally target somewhere between 20 to 30 kilocalories per kilogram of actual body weight, maybe up to 35 in really hypermetabolic states.
And protein is arguably even more critical, right? Targeting 0.8 to maybe 1.5 grams per kilogram per day. That's particularly important for trying to preserve muscle mass and promote wound healing.
Agreed. The intervention priority, as reiterated by the NEJM and others, is always individualized precision nutrition. Oral nutritional supplements are always the first-line intervention if the patient can take them.
And there's good data for that, isn't there?
Yes, large randomized controlled trials have consistently shown that fortified oral supplements, when patients adhere to them, genuinely reduce complications and improve outcomes compared to just standard hospital food alone.
But often, oral intake remains insufficient. Let's say the patient is consuming less than what, 75% of their estimated caloric goals? And we have to move on.
Correct. If oral intake isn't cutting it, we must transition to alternate feeding routes. Enteral nutrition, or EN, using the gut, is overwhelmingly the preferred route whenever the gastrointestinal tract is functional. We should really strive to start EN within 24 to 48 hours in critically ill patients if possible.
And the rationale for EN being superior is pretty solid. It preserves the integrity of the gut mucosal barrier, which helps prevent bacterial translocation, potentially reducing the risk of sepsis.
Right. It also modulates the immune system via the gut-associated lymphoid tissue, and just overall, it's associated with fewer complications, like hyperglycemia and line infections, compared to parenteral nutrition.
So parenteral nutrition, PN, feeding intravenously, is really reserved for specific situations where EN is absolutely contraindicated. Things like high-output intestinal fistulas, maybe severe ileus, refractory shock where the gut isn't perfused, or maybe short bowel syndrome where EN simply can't provide enough nutrition.
Exactly. PN demands a very careful risk-benefit analysis. Because of its complexity and the higher risk of central line infections and metabolic derangements, it absolutely requires intensive protocolized monitoring.
Okay, now let's get to the absolute cornerstone of RFS prevention. This is where the rubber really hits the road. Caloric caution. The consensus guidelines, ASPEN, ESPEN, they are incredibly strict on this point.
They are. We absolutely must initiate feeding using a conservative caloric strategy, especially for that high-risk patient we identified. The recommendation is to start very low, somewhere between 10 to 20 kilocalories per kilogram per day, or simply less than 50% of their estimated needs.
And the NEJM review was even more emphatic for the severely depleted, highest-risk patients, wasn't it? Yeah. Suggesting an initial maximum of maybe just 500 kilocalories per day total?
That's right, 500 kilocalories. It feels almost negligible when you look at, say, a 70-kilogram patient who probably needs closer to 2,000 calories. But this very low starting point is the necessary safety net. It allows the body to slowly ramp up insulin production and those anabolic processes without causing that sudden catastrophic shift of electrolytes.
Okay, start low. Then what?
Then we must gradually advance the caloric load. Guidelines generally suggest increasing the rate or the concentration incrementally over a period of maybe 4 to 7 days. This depends heavily on the patient's biochemical stability watching those labs daily. The goal is to reach the full target requirements by the end of the first week or perhaps early in the second week.
Okay, I want to pause here for a second because this is where there's maybe a little bit of conflict or at least emerging discussion in the literature. We should probably acknowledge that there is a smaller body of research starting to question if we always need to be this strictly conservative. Some studies suggest a more assertive initial feeding, maybe starting closer to 50% or even 70% of estimated needs might be safe in select populations.
That's a really crucial distinction, select populations. Those studies often involve specific, very closely monitored ICU populations, or perhaps patients whose underlying risk factors for RFS are fewer or less severe. The prevailing consensus, the reason it remains conservative, is precisely because of the potential for catastrophic harm if you get it wrong. For us as hospitalists, managing a more generalized floor population where the intensity of monitoring can sometimes vary, the risk of missing a rapid electrolyte crash is just too high to justify routinely starting aggressively. The conservative approach clearly prioritizes patient safety over reaching the caloric target a day or two quicker.
That makes sense. And that caution is reinforced by the need for proactive supplementation, right? Before we even start feeding and continuously during that refeeding phase, we have to aggressively correct any pre-existing deficiencies and anticipate emerging ones. Our focus is squarely on phosphorus, potassium, and magnesium.
Absolutely. For phosphorus, if the level is low before you start, you should begin repletion even before the first feed. We need to administer maybe 0.2 to 0.5 millimoles per kilogram per day. Often, giving intravenous potassium phosphate makes sense because it covers two needs simultaneously. This sort of preloading helps buffer the anticipated drop when insulin drives the remaining phosphate intracellularly.
Good tip. And similarly, that routine thiamine supplementation is non-discretionary for all at-risk patients. We typically recommend 100 to 300 milligrams per day, either IV or oral is usually fine, and continue it for at least 7 to 10 days. It's such a low-cost, high-impact intervention that prevents potentially devastating neurological sequelae.
Couldn't agree more. Okay, let's move to the operational side. Monitoring and treatment protocols. This is the hospitalist's daily burden, really, and it is absolutely non-negotiable.
What does essential monitoring mean?
It means daily serum checks of phosphate, potassium, magnesium, and also glucose. This level of vigilance is mandatory for at least the first week of nutritional therapy, and it really should be continued until the caloric target is reached and the electrolytes have stabilized for a couple of days.
But lab monitoring alone isn't enough, is it? Our clinical monitoring has to be just as sharp.
Absolutely. We're watching constantly for signs of fluid overload, things like rapid weight gain, new or worsening peripheral edema. That's often an early manifestation of RFS because sodium and water retention increase as the body shifts into an anabolic state.
And we also have to watch closely for any cardiorespiratory distress. New cardiac arrhythmias, a sudden onset of unexplained tachycardia or tachypnea, or any subtle signs of developing heart failure.
Okay, so what if, despite our best efforts, established RFS occurs? Meaning we see a precipitous drop in electrolytes, or the patient develops clinical symptoms like respiratory distress or a new arrhythmia. What's the protocol then?
Immediate action. First, you have to reduce or temporarily cease the caloric delivery, stop the feed, or dramatically slow it down. And you need to dramatically restrict fluid volume to manage that associated fluid overload.
Okay, stop the insult. Then what?
Then we launch into aggressive correction of the deficits. Severe hypophosphatemia, typically defined as less than 1 milligram per deciliter or maybe 0.32 millimoles per liter, requires immediate high-dose intravenous phosphate repletion. Likewise, severe hypokalemia and hypomagnesemia must be corrected immediately, often intravenously.
And only once biochemical stability is fully achieved, which might take 24, maybe even 48 hours of aggressive repletion. Only then can we cautiously reintroduce nutrition, starting again at those extremely conservative 10 to 20 kilogram per day level.
Right, back to square one, essentially.
This high-stakes, precise management absolutely demands a fully integrated, multidisciplinary approach. This is often where we can hit institutional friction, right?
Oh, yeah.
The dietitian is our expert on calculating the accurate caloric needs and choosing the right formulation. The pharmacist is critical for managing our complex electrolyte repletion orders. We might need multiple simultaneous IV infusions, which takes careful planning.
And as the hospitalist, we're leading the team. We're synthesizing the lab data, the clinical status, the nutritional plan. But the real challenge can be implementation. We might order 3 different electrolyte drips simultaneously, a phosphate drip, a potassium rider, a magnesium infusion, only for pharmacy to push back, maybe about the total fluid volume or the infusion rate concentration. Yeah. It really is our job to champion the necessity of these interventions, often having to negotiate or justify those fluid limits, because adequate, timely repletion is absolutely critical to preventing organ failure in these situations.
Well said. Now, why do we dedicate such intensive resources to this problem? It's vital we understand the clinical stakes. Let's look briefly at the complications and prognosis.
Okay. The morbidity associated just with the underlying malnutrition itself is extensive. Beyond the immune suppression we mentioned, malnutrition directly impairs fibroblast function and collagen synthesis. This leads to notoriously poor wound healing and a significantly increased risk of developing pressure ulcers.
And that functional decline, the generalized weakness and frailty, is often what keeps patients in the hospital longer and frequently prevents them from returning directly home. It drives disposition challenges.
Definitely. The underlying malnutrition fuels a significantly higher risk of hospital-acquired infections, leads to longer antibiotic courses, and just generally prolongs hospitalization. And this risk is compounded by that inflammation-driven catabolism we talked about, making the patient somewhat resistant to therapy and increasing their baseline mortality risk even before any RFS event occurs.
And then when RFS is superimposed on that already vulnerable patient, the prognosis deteriorates dramatically. The syndrome itself is a powerful, independent, poor prognostic indicator. I remember seeing one secondary analysis of a large randomized trial where patients who developed RFS had a significantly increased 180-day mortality. The adjusted odds ratio was something like 1.53 compared to similar malnourished controls who didn't develop the syndrome.
That's a huge impact on mortality.
It is. And furthermore, RFS is consistently associated with massively prolonged hospitalization. Pooled data suggests the average length of stay in affected individuals often exceeds 25 days. That's a huge economic burden, not to mention the physical burden on the patient. And it comes with significantly higher rates of ICU admission and the need for mechanical ventilation.
And part of the danger is the insidious nature of RFS, meaning it's frequently underrecognized, isn't it?
Yeah.
We're used to reacting to critically low electrolyte numbers, but the early signs may be a subtle new onset of pitting edema, a mild unexplained tachycardia, Those can sometimes be dismissed as, oh, that's just the patient being frail or sick.
Exactly. This variable and sometimes subtle presentation means the syndrome often progresses significantly before a truly life-threatening biochemical change finally forces our hand.
So mitigation, therefore, relies almost entirely on our proactive vigilance and just strict adherence to those conservative evidence-based management protocols we've been discussing.
Right. And while these conservative initiation strategies are designed to mitigate that excess mortality associated with RFS, we have to remember, the mere diagnosis of RFS reflects the extreme severity of the patient's underlying depletion. So even with optimal management, their inherent prognosis often remains guarded.
Okay, this brings us squarely to our final section, the hospitalist responsibility and the clinical imperative. We, as hospitalists, are really the central orchestrators of this complex care delivery.
Our primary role is comprehensive, isn't it? Systematic identification through screening and robust risk stratification for RFS that has to be standard practice for every single admission. If risk is present, we must personally ensure that the cautious refeeding protocol is initiated correctly and, importantly, enforced across the entire care team.
That includes implementing the prophylactic thiamine and ensuring those key electrolytes, phosphate, potassium, magnesium, are ordered for repletion if needed before starting feeds ideally, and ensuring that absolute mandatory daily monitoring of those same electrolytes happens.
We are responsible for synthesizing that data day to day, recognizing the alias subtle signs of RFS manifestation, and coordinating the prompt, often aggressive, correction of any deficiencies that emerge.
And our responsibility extends beyond the acute hospitalization, doesn't it? The hospitalist must also ensure seamless transition planning. We need to confirm that adequate nutritional support will continue after discharge, whether as oral supplements, tube feeds, or coordinating outpatient follow-up. And providing patient and caregiver education on sustained recovery and how to prevent recurrence is key. We need to establish a true continuum of care to try and break that cycle of malnutrition and readmission.
Agreed. So we've spent significant time discussing the prevailing consensus, which is strongly reinforced by the NEJM and major societies like ASPEN and ESPENs. And that consensus overwhelmingly advocates for that conservative initial caloric advancement, sticking to that 10 to 20 kilocalories per kilogram per day limit, especially in high-risk patients, specifically to prevent life-threatening RFS.
Yet, as we touched on, we have to acknowledge the emerging research suggesting that with perfect, rigorous, daily, maybe even twice-daily monitoring in some cases, a slightly more assertive approach might theoretically be safe in very select circumstances.
Right, and this raises the profound, real-world, clinical, and institutional question for every practicing hospitalist out there listening. Are our current hospital resources, our dedicated nutrition support teams, our lab turnaround times, our pharmacy capabilities, our nursing staffing levels, are they truly adequate to provide the intensive daily, sometimes hourly monitoring required to safely even attempt a more assertive refeeding protocol outside of a specialized ICU?
That's the crux of it, isn't it?
It is. Or, given the profound and largely preventable morbidity and mortality associated with established RFS, does the weight of the evidence compel us to strictly err on the side of caution? Should we adhere rigorously to that conservative initiation, that 10 to 20 kilocal per kilogram per day limit, recognizing that this choice fundamentally impacts patient safety, even if it also impacts operational resource allocation like length of stay?
That's the decision we face every day at the bedside with these vulnerable patients.
It is.
So, to summarize this entire deep dive, maybe the key takeaways for every admission should be: screen universally for malnutrition risk using a validated tool. If malnutrition is present, execute a separate specific risk stratification for RFS. Supplement thiamine proactively in all at-risk patients, and replete key electrolytes, phosphate, potassium, magnesium aggressively before and during feeding.
And critically, start nutritional support low and slow, targeting that 10 to 20 kilocalories per kilogram per day initially for high-risk individuals, with vigilant daily lab monitoring of phosphate, potassium, and magnesium for at least that critical first week or until stable.
Apply these protocols aggressively yet conservatively. Your vigilance really is the patient's ultimate safety net in this situation.
Absolutely, it requires constant attention.